again, because Sokransky in 1998 postulated these different colors that you see on the screen. So these are called your colonizers, your primary and secondary colonizers. Your yellow complexes, your green complexes, your blue complexes are the primary colonizers. Now, why are they called primary colonizers? Is because these complexes attach to the knife surface of the tooth like a pellicle. So they get attached and they release some nutrients or some excretory material, or they have some appendages to which the secondary complex comes and attaches, and that comprises of orange and red complexes. Now, these are the dangerous ones because they are responsible for the destruction of the attachment. They're responsible for deeper probing depths. They're responsible for the bleeding and probing. So, and they are resistant to most of your mechanical therapies. So, whenever we are doing some sort of scaling and root planing, maybe you take care of the yellow complexes, but it's almost impossible to take care of the yellow, the orange and red complex with the help of your mechanical therapy. Now, what does this complexes do? Now, these complexes are present in form of biofilms. Okay. Now, you have a tooth structure, and then you have a biofilm attaching. So these complexes stack upon one to another, and they form a very dense structure, which is known as biofilm. And this biofilm is nothing but co-aggregation of a lot of pathogens, and these pathogens elicits some sort of inflammatory response. So they lead to release of a lot of prostaglandins, interleukin 1, interleukin 6, and all of this together leads to a lot of attachment loss and inflammation in the body. So periodontal disease is just not microbial disease, it's also a host who is susceptible to have a periodontal disease, which together in combination, it leads to attachment loss and bone resorption, and thus that is called periodontitis. Now, the understanding of periodontal disease and treatment of periodontal disease has become even more important because it doesn't only affect your oral cavity or the mouth, it is also systemically related. Now, we have so much of literature and the landmark study by Offenbacher, which talks about the relation of the gums with your pregnancy, with your hypertension, diabetes. It's an established fact that it's a two-way relationship with the diabetes mellitus, which means when your periodontal infection goes up, you have more of glucose levels in the body because of the inflammation, the insulin resistance happens. And when you control your diabetes and when your sugar level goes down, your inflammation in the gum also comes down. So it's systemically related. It's related to your pregnancy because your abnormal inflammatory markers in the mouth because of periodontal disease may lead to your preterm low birth weight in the children or some sorts of miscarriages. So your control of inflammation is very important, and an era which is like a post-COVID era, it's even become more important because COVID is just not an infectious disease, but it's also an inflammatory disease. And we know that when somebody contracts COVID, we talk about the testing like COVID markers, which includes your dimer test, interleukin 6, CRP. So these are the common markers which are common to the periodontal disease and COVID again. So honestly, COVID has been an eye opener for me because ever since we have been facing this unprecedented wave, I see and refer, I've been referred a lot of patients who have been suffering from COVID or who are recovering, and they are being referred to me for loose teeth, bleeding gums, halitosis, and a lot of mobility in the teeth. So this is because when you contract COVID, your body's inflammation goes up, and so your oral inflammation goes up, and your gum starts to bleed more. Or if somebody already has a periodontal disease, it can worsen, and the vice versa. If you have a periodontal disease and if you do not control it, and then you contract COVID, and your markers are towards your higher side, then your periodontal infection and the inflammation is actually going to contribute to your cytokine storm and is going to become even worse. So this knowledge and awareness about the same is important as for us to know it as dentists and professionals, and the same has to be shared with our patients. So we talk about what is a periodontal disease primarily. Now, let us understand when we talk about periodontal treatment, what does it comprises of? Now, when we talk about periodontal treatment, we talk about non-surgical therapy, and the second we talk about the surgical therapy. Now, both of them comprises of ultrasonics, conics, sonics, and your scalers, curettes, and root planers, which everybody knows and have been using. We also use systemic antibiotics and local drug deliveries. Why? Because biofilm is a dense structure and you need to mechanically break that biofilm so your antibiotics enter. And sometimes most of the bacteria are resistant to the antibiotics and they don't respond to the systemic antibiotics or the combination of amoxicillin and metronidazole. So you need to get in with some other therapy, maybe some laser therapy or photodynamic therapy that helps as an adjunct for the body or the tissues to heal faster. And you also use sometimes some bladed instruments, Kirkland knives, your mini blades, your scalpels to get rid of the infectious epithelium lining outside and inside the pocket. Now, when we talk about the treatment of periodontal disease, we talk about majorly about your pocket elimination and pocket correction techniques. Now, they comprises of your apically positioned flap, your modified Whitman flaps, your Whitman flaps. So this is what the protocol looks like, and why your treatment comprises mostly of your surgical treatments. So either we talk about the scaling root planing or we just jump to the flaps. Why are we not talking about something that lies in between? Is because if you see the landmark study by Dr. Verhoek in 1978, he talks about the limitation of mechanical instrumentation beyond a certain depth, which is 5 millimeters. He says, and he's postulated in a study which talks about a mechanical instrument, be a scaler or a curette, cannot reach to a level beyond 5 millimeter with that efficacy. And also, the moment you go deeper, when you have deeper pockets, for instance, 7 millimeters or 10 millimeters, you have bacteria which are more dense. They are tenaciously attached to the root surfaces, and they are actually bread complexes and anaerobes, which are resistant to your most of the therapies. So it becomes difficult to treat the pockets beyond 5 millimeter with a non-surgical therapy, and you are left with the option of now flaps. Now, the other downside or the flaps, or why the patients turn down when they are offered the treatment of surgical therapy, is because number one, they sound invasive. Number two, they require local anesthetics. Number three, it requires a lot of blood, and often they number four, they lead into recession and sensitivity post procedures, and that is the reason that either we just do scaling and do planings, and or else we do not do anything, and this whole treatment or this periodontal infections, they are being neglected. So most of these teeth which are actually salvageable unfortunately go for implants because we don't have the understanding of the periodontal disease and the science behind the treatment. And if we do that, then we are able to save. So let's see if during the presentation we can find some midway of saving these teeth and not replacing them, all of them, with the implants. Now, laser is one such tool which is acting on both the constituents of the periodontal disease. A laser, like I said, you have these biofilms which are super resistant to your mechanical therapy, your complexes like your red complex, your orange complex. So this laser has been postulated to have a bactericidal effect. Now you have different kind of lasers; they may have different kind of action, but they all lead to bacteriostatic and cidal action because they absorb the water of the bacteria. And this the same has been postulated by a landmark study by Dr. Alan Oder, where he did a study with the combination of a diode laser 940 nanometer with the help of H2O2 vents, and he saw that there was a significant reduction in the complexes in comparison to just mere scaling and planing. So yes, one of the factor of the periodontal disease, which is microbes, is taken care of with the laser. Let's look at the other factor. The other factor, like I said, the microbial gelin leads the host to release some cytokines and some inflammatory markers like prostaglandins, interleukin, matrix metalloproteinases, tumor necrosis factor. All these factors are